Before we begin, I would like to emphasize that this podcast is separate from my teachings and work at Dell Seton Medical Center. Any discussions we have on this podcast is for entertainment purposes only and in no way connected to Dell Seton Medical Center. Welcome, everyone, to another episode of the Life of Flow podcast. Today, we had an amazing episode with Giacomo and Andrea. They are two physicians that work together in Italy. One is a podiatrist,
internal medicine
that
subspecialized in
subspecializes in podiatry, and the other one is a vascular surgeon. And we're going to talk to them about their pioneering experience in deep venous arterialization, the ins and outs, how they dove into that, and the great outcomes and kind of like the forerunners of this that they are. So it was a great conversation.
Very fun.
And I hope you guys enjoy it.
Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast. Welcome to yet another episode of Life of Flow. My name is Miguel Montero Baker, and I am your co-host together with
Lucas Ferrer.
And again, this is one of the series that we are recording in a very special place because we came to the Hendolat meeting, which is I would say probably one of the main meetings in Latin America for vascular and endovascular therapy, a multidisciplinary place of gathering of also friends, because I think that's what's made Hendolat very special. It's you got to know somebody to come. You just don't get invited. It's really by invitation only of close friends, and that makes it special. But anyway, we at the Life of Flow podcast had the dream that we could be here and spend some time with our good friends and having discussions that we normally don't get to have. And as you all know, part of the podcast's je ne sais quoi kind of way of being, modus operandi, is we want to have these discussions that are almost like those discussions at the end of the day with a good whiskey or a good wine. So today we have a real pleasure. This is a super awesome podcast. I'm already incredibly excited because we have two of our good friends from Italy, Dr. Andrea Casini to my right. Andrea, hello.
Hello.
And also Dr. Giacomo Clerici. Hello, Giacomo.
Hello, thank you for having me.
It's awesome. Giacomo, you are a podiatrist, correct?
Actually, I am specialized in internal medicine, and after that, I had a training for more than 5 years in surgery, in diabetic foot surgery, and so I am a sort of specialized in foot surgery, in particular in diabetic foot surgery.
But from a background of internal medicine.
Yeah,
That's
I am
really cool.
Yeah.
That's
Started
really cool.
as an internal medicine student, and after that, after 5 years, I decided to go ahead with my specialty in foot care, in diabetic foot care.
I love that.
And how long was that training in Italy?
So in internal medicine, 5 years. After 6 years of medicine. So after 6 years, you have other 5 years for internal medicine. Yeah, exactly.
That's cool. I didn't know that.
Oh,
You
really?
you can't do that in the U.S. You can't be an internal medicine guy and then become a surgeon. I mean, unless you do a surgical training.
Yeah. I think all around the world is the same. Just
You
in Italy.
can't. You can't become a surgeon and get privileges at a hospital.
No, yeah.
You wouldn't be able to do this.
But the reason was because in the, I think, end of the 80s, beginning of the 90s, I started my career in diabetic foot care in the middle of the 90s. So today is almost 30 years career, 30 years experience. But in that period, in the middle of the 90s, no one wanted to take care of these patients because the only therapy they offered was the major amputations.
Yeah.
And so some diabetologists in Italy, some pioneers, started to do surgery, started to work with orthopedics in the operating theater, with plastic surgery, surgeons,
Oh.
with vascular surgeons, and try to steal some tricks for surgery. So after that, I had a training for many years with many colleagues in specializing in plastic surgery or in orthopedics, and this was the reason why, as an internal medicine specialist, became a foot surgeon.
So is this? I mean, obviously, you made this. You made your own path. You created this out of interest, but out of the need of these patients. But if somebody now says, "I want to be like Giacomo Clerici,"
Impossible.
there is only one.
Yes, it is possible.
No, but let's say, I'm a young, medical student, and I want to follow your career, and I'm in Italy,
Yep.
because obviously it's very different by country. What would be the way to follow your steps professionally?
Actually, I would recommend to be part of of a multidisciplinary team, and after that, if you want to do surgery, I think that you must be specialized in foot surgery, like orthopedics or even vascular surgeons, etc. I think that today the time is completely different if you compare when we started in the middle of the 90s. So I would suggest to take the specialty in orthopedics, because in Italy we do not have podiatrists, we have podologists, but podologists are not
Non-surgical.
exactly. They are just medical, a sort of medical specialty, even if it is not a medical specialty, but they are not surgeons. So we do not have podiatrists. We have orthopedics specialized in foot and ankle surgery. And I think that the first step could be this one. And or you can take another, for example, general surgeon, and then you can follow, you can attend some courses, etc., in order to become a foot surgeon, diabetic foot surgeon, or even a vascular surgeon. Why not? And if you want to be a specialist in wound care, you can, of course, to be even an internal medicine specialist or dermatologist or whatever you want.
Okay. And Andrea, you're a vascular surgeon.
Yes, traditional.
Traditional vascular surgery.
Traditional.
What's
vascular
traditional vascular surgery
Open
in
surgery.
Italy? You do medical school, then you do general surgery.
You need the same degrees, and then you do the specialty in vascular surgery that are 5 years in Italy.
So it's straight from medical school. You can go into vascular surgery. It's a 5-year
5
program.
years only of vascular surgery.
Do you have the fellowship way that we have in the US, where you can become a general surgeon and then do 2 years of vascular?
No, in Italy it's completely different. We have 5 years dedicated to vascular surgery. We did not the following general surgery.
Okay, so that's the only way to get.
Only way, yeah.
All right, guys. Well, let's try to dive into what we wanted to talk. And I think one of the reasons I was talking to Lucas about, we were hoping we can get you guys to sit down with us for a little bit, was because of a very unjust and unfair topic that we have given you guys. Because today I gave 8 minutes in an hour and a half session, but I told Andrea, you have 8 minutes to summarize your group's experience of 7 years or more of doing venous arterialization for the no option CLTI patient. And so I thought that was a little unfair, because I'm sure that within 7 years, there's a lot of things, maybe not even scientific, that we may want to talk about here today in the evolution of the technique.
You know, one thing that's always I love about Italians giving presentations is that even though you give them 7, 8, 5 minutes, they always sneak a little bit about philosophy into your presentation, so you learn about everything.
These
in
guys
7
are the
minutes.
godfathers.
I
of,
know.
like,
They're like
they just make it so cool.
I just wanna,
right?
like,
the
yeah,
presentations
listen
are
to them in my
so
car.
cool. If you haven't seen either Roberto, Andrea, or Giacomo, go out of your way and find them, because
Yeah.
their meetings are it's almost like a philosophical class
Yeah.
with some science. And but anyway, so maybe let's go back. Let's start before the 7 years. You guys were all working together still. How long have you
Yes.
two known each other?
more or less 20 years.
20 years.
20 years, and
Yeah,
you're
yeah.
still friends.
Yeah, yeah.
Yes.
More.
Better than a marriage.
Actually, yes, more.
Better than a marriage.
There have been a few wives in the middle.
Not,
Hello?
not me, not me, not me. Andrea is,
Not
is
yet.
an expert.
Andrea
He's
is,
an expert.
yeah,
Not
is an
yet.
expert monogamist.
Don't say no.
Okay, so you guys have known each other for almost 20 years. You
Yeah.
have worked together also for 20 years. How about Roberto? Is Roberto been also part of this team for that many years?
I met Roberto I think around 10 years ago or better. I knew Roberto many years ago, but he was used to work with another team with Carlo Caravaggi, another diabetologist who became a foot surgeon, a very good foot surgeon. And after that, we joined Roberto in Bergamo because he needed a team dedicated to the diabetic foot care. And so I think that I met Roberto around 2015, so more or less 8-10 years ago. I think around that date. Yeah.
And so, by the way, for those listening in and don't know Roberto Ferraresi is the third part of this dream team, and Roberto is an interventional cardiologist.
Yeah.
And I think at this by now you're probably connecting the dots. That is exactly how these patients need to be cared for. You need to have the foot surgeon expert wound care management. You have the vascular surgeon with open abilities, and then you have also somebody that's phenomenal at wires. And I think this is a very interesting concept that you guys have taught us so through many years, right? And I trained with Joe Meals and I trained with David Armstrong, also trying to bring together the foot surgery and the vascular care into the daily practice. But anyway,
Did that happen organically that you guys decided, oh, we need a vascular surgeon and interventional cardio and a podiatrist? Or is that just because you were friends and you like working with each other? Or
From my point of view, I started a little bit earlier because I am a little bit older than Andrea. And when I started in the middle of the 90s, I was very lucky because I met Ezio Faglia. Ezio Faglia was an amazing person and a brilliant brain. Unfortunately, is not here yet. Or actually anymore. But when we start, we work in a small group. But year after year, we understood that we needed more person involved. So we started with an interventional radiologist, but then we understood that we needed a vascular surgeon. After that, we needed a podologist. We needed wound care nurse specialist, etc., etc. So the group started very small, and after that became very big.
and is this in a setting of like a private practice or the government hospital? Or
It's a good question. In Italy, we have more or less three ways. We have a public hospital, very good because we have the universal coverage for everyone. No one has to pay anything for the treatment. We have private hospitals with a dealing with the health national system. It means that you are private, but you work like a public hospital. This is our situation. We work in a private hospital, but our patients do not pay anything for the treatment because it's paid by the government, it's paid by the country, the healthcare system. And then there are some pure private hospitals, but usually for diabetic foot, no one goes to the private hospital because our population, our patients, our people with diabetes and foot problems are in I think in a middle class or lower classes, and so I think the most used hospital is the public or private with the public deal.
yeah.
so Andrea, let me pull you in with, you said 7 years of experience. So I'm guessing before the 7 years, you had already, as a group maybe, or maybe Roberto, I don't know, you tell me, had recognized that there was this really difficult pattern of disease and you were losing the fights. You were losing every fight, I'm guessing, and it was probably very frustrated because that's kind of how I started. But I want to hear it, When did you guys start saying, man, we got to do something else? Something's not working for us in these patients.
About arterialization.
Yeah, we're going to talk about your arterialization experience. So I want to know, before you started doing the first cases, you were probably finding a lot of frustration with some of the bad results you were having, huh?
Yes, but we must be honest. Before the first case, I didn't know anything about arterialization. Is my fault. I never read something about this kind of procedure. And the first case I remember, like was yesterday, and in the OR was me and Giacomo. So imagine a vascular surgeon and an internal medicine specialist perform the first arterialization. What happens? It was a patient in which we do a lot of mistake because the patient was admitted for a CLTI. We studied the patient with the anterograph approach. The patient has the patency of all the artery, ATK, BTK, BTA, and so the question is who is charged? This patient, it's a failure, it's not an ischemic patient, so we dismiss the patient. And after 1 week, we admitted the patient again because the clinical status was worsening, because the rest pain was much higher, and there is also the cyanosis of the first toe. So we admitted the patient again and studied the patient with a contralateral approach. The contralateral approach shows that we miss an iliac plaque that due to an embolization, and so the patient has a complete thrombosis of the pedal and posterior tibial vessel. It was a problem because it was not simple. I bring the patient in the OR and I start with the thrombectomy of the pedal artery and the posterior tibial artery. Perhaps the success was 1 hour. The patient going subacute ischemia, so I bring up the patient again in the OR, do the same procedure, and the patient was failed. The procedure was failed. So we was in the OR with Giacomo planning a BTK amputation. And the patient was not so happy because he told us, but I come for the rest pain, I lose my leg, why? And so I looked to Giacomo and told him, bah, try to do something. We have a posterior tibial artery. I saw a posterior tibial vein. Try to do an anastomosis from the posterior tibial vein to the posterior tibial artery. He looked at me and he told me, we will go in the jail? Perhaps no, but I don't know.
But you had seen this
Never.
about arterialization.
Yeah, never.
You
never.
had not seen the talk.
Never
Nobody had said anything.
Never idea.
You're there in the middle of this case, and you're just like,
Yeah, I have a posterior tibial artery.
you say, F it. I'm going to try something because
Try
I got to give
something
this guy an option.
Based on the theory that when you do a bypass and you have a high resistance outflow, you do a fistula.
Yes, this is a very old
technique.
So old technique in surgery. If you have bad outflow, you can do a fistula so that you let the bypass have some outflow.
Perfect. You increase the resistance, peripheral resistance. So I take the artery in a terminal way and attach to posterior tibial vein, do the endovalvulectomy with a Fogarty catheter. We complete the anastomosis, and what happened? Happened that the patient is going well, with a reduction of the rest pain, and we complete the procedure with a short part amputation, leave it open because there was a major tissue loss. So we cover with a dermal substitute, and after a couple of months, we cover with skin graft, the patient was healed.
No way.
And yes, and after 5 years, the patient is still without rest pain and healed.
And you're out of jail.
No,
You didn't go to jail.
Till now, no, because
You're
we didn't say anything to the patient. So this is, in our mind, was rising the question, we can do something different. And so we, at this time, we work with Jacques Clerici, that in my opinion is a phenomenon in interventional radiology. One of the most beautiful hands that I saw.
Where does he work?
And now he worked through Panama and Canada.
Retired.
Fishing.
But was one, I think, was one of the most. I think maybe it is still today. He is still today one of the most. I think I could say
Genius.
master
It's a
genius
genius.
in the endovascular.
He's an
was able-
interventional radiologist
Yeah,
from
yeah.
Italy.
No,
From
from
France.
France.
From France.
Absolutely.
Do you want to know something very special, very funny? His name is Jacques Clerici.
Yeah.
In
Is it
Italian, is
exactly?
Giacomo Clerici.
No.
Yeah. Perhaps I'm the same person, but I don't know.
Maybe.
Clones.
I would like. I would love.
I figure me and
He was,
Giacomo.
he has two hands.
Beautiful.
Magic.
And how did you guys connect?
We work together in
First
the first hospital. And
Oh, so he was
Yes.
French, but he was working in Italy.
In Sofaglia, we were in the multi-medical hospital
Okay.
in Milan.
Okay.
And
So-
he was the interventional radiologist of multimedica. So I started to work with him in the multimedica.
Got it. Okay.
So the rising question, me and Giacomo, is without any kind of arteries on the foot, why we didn't use the vein system? We speak with Jacques Clerici. For Jacques Clerici, everything is simple. Everything is simple. You ask Clerici, I have a fistula on the brain. Don't worry, we embolize.
It was a-
You have anything.
He can do anything.
Anything.
We're gonna have to get him on
Yeah,
the show
we're
one
gonna
day.
get him on the show.
That sounds like an
Yeah.
incredible human.
Anything.
I like to do the same relationship. Sorry. I like to think about Jacques Clerici as the Pelé or Maradona of the situation. The same.
Okay.
Wow.
Okay. I get it. Okay.
So,
And so you talk to him, and he's like,
Yes.
"Oh, it's easy."
oh yes, it's feasible. It's feasible. Yes.
And he would speak Italian.
Yeah.
He learned the language.
Yes, very well.
Speaks very well.
Better than us.
Not difficult.
So a week later, we admitted to a hospital a patient of Giacomo with rest pain gangrene. It was a very fancy 82 years old woman. We studied with the angio and show a completely no option. So we go to the patient and we told to the patient, you require a BTK amputation. I don't think so. The answer of the patient. You don't think so, but it's the only way that we can carry on your life. No, I can go to the theater without one leg. No, you can go. You wear a prosthesis.
Like,
no.
She wanted to go to the opera.
The
Orchestra. She's very fancy.
I have a lot of shoes, and I can go to the opera. So I speak with Giacomo and try the second.
Side comment is always funny when these patients come to the lab. I know it's kind of not funny, but
Yeah.
it's they come with gangrene, but their nails are beautifully
I know.
polished.
Yeah. I know.
We have a
Yes.
lot of pictures.
Yeah.
I've always found this
It's
very interesting.
amazing,
It's like,
yeah.
this is in español dicen antes muerta que sencilla.
Yeah. Probably
I
a
would
good
die
sign, probably a
before
good
I
sign of
lose my-
compliance.
Yeah.
Probably-
But anyway,
yeah.
okay, so
Yeah.
this lady wants something to go to the opera.
But not the BTK amputation to go to the opera. And so we try to do the second way. And the patient hasn't the saphenous vein because naturally she underwent to saphenectomy in the young age.
Of course, for her varicose veins.
For her aesthetic, the problem is the telangiectasis. And we bring the patient in the OR and we do the first bypass using heparin-banded PTF graft from the popliteal artery to the posterior tibial vein. Then I call Clerici, that destroy everything, the anastomosis, the posterior tibial vein, the plantar vein. But I think it was a genius, and we can find the exit way without know everything. And the patient underwent a TMA amputation, and after 3 months, he go to the opera with her shoes. And so was raising much more the idea that something could change with this technique. And the third case was the arterialization of a patient, a similar patient, using the Grissa-Venous vein. Then we met Roberto. We share our experience with Roberto that was starting to work with the Lymph Flow project. And
Do you remember the year?
2016,
I think so.
2016.
Okay.
2016, yes, when we joined him in
Fortu-
Gavazzeni
yes,
Hospital.
fortunately, we go to work together, Giacomo, me, and Roberto, and start to do and start to arterialize everything. Everything.
Every no option patient.
Every no option patient, we arterialize. Bilateral, dialysis, diabetes, everything.
Yeah.
And the learning curve was very, very, very hard. We have a lot of bleeding in the cath lab. We had a lot of rupture of the proximal distal anastomosis. Roberto that told me, you are not able to do the anastomosis. And I told Roberto, you are not able to dilate the vein. So there was a lot of fighting. Then
Moments of tension.
when
Well,
when-
imagine
It
if
probably
you-
sounds great in Italian, though. Sounds probably great.
Well, imagine if you're there doing a bypass
Yeah.
and it takes you, you're dissecting, you're getting
Yeah.
proximal
Yeah.
control, distal, you're using a 7-0 Proline, beautiful, and it looks beautiful. And then this
Bello.
dick guy comes with catheters and an 034
Yeah,
wire,
just like-
trying to like break all the valves.
Yes.
And he ripped the anastomosis and
Yeah.
then said, you don't know how to do an anastomosis.
Exactly.
If you-
This is what
Typical
happened.
cardiologist.
This is what happened.
Cardiologist.
It's not my fault. It's not my fault.
It's not my fault because at the beginning we do the endovalvulectomy with a with a big size balloon. So we treat a vein of 1 millimeter and he used 5 millimeters balloon.
Yeah.
What the fuck? It's normal. It's normal that you broke everything. So, but the week pass and I try to modify my technique. So I change the length of the anastomosis because I do a traditional anastomosis. So I think perhaps I have to change the angle of my landing on the vein. I have to change the length on anastomosis. So I change the angle, more acute angle, more long anastomosis, and the result was better because I allow Roberto to pass with the guide wire, with the catheter, with the balloon, and so we developed the hybrid technique both in a deep plantar system than in superficial dorsal.
So you're saying Roberto was right?
Yes. No. we finally arrived at an agreement. And then I think that the result was the same. And so I think why I have to spend a lot of time by do an arterialization on the deep plantar system. It's easier, the hybrid on the superficial dorsal system is faster, is safer, and we continue to do and stress the arterialization of superficial dorsal system till nowadays, in which we think we arrive to the final, till now, solution that is the monoaccess to avoid the instances of the distal approach. We understand which collateral you have to coiling in the early for focalize the blood flow. We have standardized the exit way from the first toe vein and the metatarsal branch. Now we have understand a little bit more things than before, and so that's how born the arterialization, born for a very desperate patient in which perhaps we felt more guilty for misleading the disease of the patient that was leading to amputation.
At the same time, you guys are developing this, and you are having more and more cases, and you're also giving the foot surgeon more and more cases. But now we know that the foot surgery is completely different.
Yeah.
And so tell me a little bit, Giacomo, as you guys are developing, at what point did you say,
No,
What the fuck? I, what
no,
I've
no,
done
no.
my entire life is not working, and I'm going to have to learn how to reoperate these patients. When did you come to this? I'm sure it's over multiple failures, sadly, but obviously you've now taught so many of us that we now know what to do, and we thank you for that. But share a little bit of your perspective as you were.
I want to add a part of the story because your question is the second part of the story. We were good, or better, they were good in this kind of new revascularization, but actually at the beginning we failed a lot in foot surgery, in the outcomes of the foot surgery, because we use the same rules we have for a regular diabetic foot patient. That is to, when there is no infection, to do a closure for first intention, etc., etc. So we understood that looking at the pictures of the angiogram when they do the embolization, the second, the third, etc., that something during the months, during the weeks was changing, and we had new vessels, new networks, etc. And so we understood, because we had some cases where we carry out the, for example, a transmetatarsal amputation with primary closure, skin, with the suture of the skin, with the stapler, etc. We saw many failed patients, and so looking at the picture and considering the fate of these patients, we understood that we had to change our routine. And our routine today is that we understood that we have to wait and see what happens clinically from an angiographic point of view, etc. And for example, checking the patients with the TCPO2, checking the patients with the angiogram during the embolization, etc. We understood that we have to wait at least 45, 60, 90 days, and your success increases until you, if you wait a lot, because you have a very good network, you have a very good new vessels, new arteries, because the acute result is not useless, is not useful for the foot. You have a very good pictures if you look at the acute result after an arterialization, but from a physiological point of view, you do not have a useful blood flow.
Now, do you, as a foot surgeon, that maybe you never had to, but do you see yourself understanding more on the vascular side? Like, do you look at the angiograms? Do you look at the focalization?
Sure.
Do you look at is it medial marginal or is it lateral plantar? Because I feel this is a part where, at least in my practice, that's where I've had to push a lot more on my podiatrist to say, no, I need you to come into the room.
Exactly.
I need you to look at these angiograms.
Sure.
You cannot do a surgery unless you've seen the angiograms.
Yeah.
And if you don't know the vessels, you need to learn the vessels. Because if you're going to operate on these patients, you need to know where you're going to cut and how you're going to cut. So do you feel like you know angiography at this point?
This is a very good point. It is a very good question, because I have learned a lot from vascular surgeons and interventional radiologists, because in the 90s, but also in 2010, 2000, we were used to go to the meeting, to the conferences, podiatrists in one part, the conference of vascular surgery in another, etc., etc. You talked about arteries, we talked about biomechanics, and when we started to do conferences together, when the toe and flow teams started to do this kind of meeting together, we learned a lot from each other. I think that usually vascular surgeons or interventional radiologists are not so used to talk about biomechanics. Today, I have seen many lectures about vascular surgeons. They are very good in biomechanics. It is incredible, and I have to say that this was a very fruitful exchange. Absolutely.
So,
Miguel,
yeah.
I think Do you remember the first hybrid DVA we did, and when I was a fellow?
There are a lot of things from when you were a fellow that I have purposely forgotten and removed out of my hard drive. So if it's more engraved than yours, I would love you to share, but I'm not sure what you're going to say.
We had this young patient that came in with like some form of
Oh, of course I do.
Yeah, I remember that. And we go in and we saw, I think we had seen a perineal, and we were going to do a femperneal bypass or something like that. We go in, we take the fibula out, look at the perineal, it's shit, right? So then we look at the angiogram again, we're scratching our heads what we're going to do, and then we say, oh, maybe there's a PT. So we go get the PT. Oh, there's the PT. We find it. We do the anastomosis.
I think I remember that.
And then we put the Doppler on it, and it doesn't sound arterial. It sounds like a vein. So then you rip the gown off. You go outside, and I'm like, they're waiting. I'm like,
I needed a timeout.
Yeah.
So meaning
And
that,
then
just to follow. So we had done the anastomosis, thinking it was a posterior tibial artery, but we connected it to the vein in the
vein
foot.
on the foot. Yeah.
And it didn't sound that good, probably.
And it sounded super low resistance and just like,
Or like,
yeah,
it was just going up.
Yeah, it sounded like, yeah.
Okay.
And then you come back, you say, everything's fine. Everything's fine. I think you had called Roberto. And you said, hey, I think I connected this. I think I did like a hybrid DVA by mistake. And then we came back. We did the endovalvulectomy. She was in horrible
Yeah, I remember she was in severe
horrible
pain.
pain. We come back. I think you made another phone call. We come back to do the TMA. Pain's resolved. And she healed.
No, she's still walking. She's
still walking, yeah.
And that was a case I remember texting you, texting Giacomo, texting, Roberto. But, some serendipity sometimes.
Serendipity, man.
And it was the only reason was because I had heard a talk at some point here, maybe Endolat or some other place. And I'm probably, saying really bad words outside trying to figure out what we're going to do because it was that or a, major amputation. And she was young woman. But it worked out. It worked out. And then we had some pretty bad, tough cases. Dehiscence of the wounds, swelling, infection of grafts, exposure. I saw the PTFE stent in the saphenous vein. I did that too. It did also exposed. So
It's funny how the first one for a lot of people works.
Yes.
But then you're like, oh, I'm so good at this.
Yeah.
And then you do more and more, and then they start failing.
Kumar was saying that earlier in his college. He's like, he did one, it worked, and then he's like, oh man, I'm so good. And then everything after that was horrible.
So my first,
maybe if the first didn't work, we didn't.
Correct.
I think
you would have not continued.
We were very lucky, and the patients today are very lucky because of these experiences.
It's God's way of helping his client.
My first one, and you gave me a lot of shit about it too. When I was by myself in San Antonio, is I go in.
I really didn't care about it. I gave you a lot of shit when we put the patients together to publish.
Yeah. Well, still, because it's fun, it's hilarious.
No, but let me tell you why.
Yeah.
Because I get to the point. By the time he finishes training, we are the pure. To your point, like, hey, this guy gets this. This guy gets this. We do it this way. We've learned a lot. God bless you. Go on your way. Fly, little birdie. And he goes to San Antonio. Like always, you don't hear about them a lot. And then he's like, hey, I've done some DVAs. And I say, oh, we're putting our paper together. Send us your data. My resident talks to him. They finish. Paper comes written. And I wanted this paper to be hybrid, single incision, GSV, and endo DVA. And I'm reading through and it says, a artegraft, bovine carotid graft was used. And I'm reading this. What is this shit? And I call my resident. What are you? He said, I don't know. Dr. Ferrer's cases are weird, are all over the place. And then it was like a PTFE. I don't know what. Like you did some crazy.
Because I
shit.
didn't have anything. I didn't have anything. I go in. The ultrasound
a cow carotid you
the
used.
ultrasound was completely wrong. I go, this young guy, I remember he still has his leg. I go in, teacher, still teaching. Like, that's how he, like, and I developed a relationship with this guy, and I tried the traditional approach, didn't work. So I'm there, and I ultrasound is like good vein. So I go in, and the vein is shit, complete shit, right? So I say, okay, what do we have? Oh, we just have like an 8 PTFE, ring PTFE, and then we have like a 5 bovine carotid. I said, okay. Give me the bovine
Yeah,
carotid.
cow carotid sounds
Yeah.
exceptionally good.
I said, okay, well, give
So
me that.
much for
Yeah.
standardization of technique.
Yeah, well, that's what happens when you like go into like some.
I like it.
Yeah, and the guy worked.
It worked. It worked well.
First one, and it worked.
That's
That's
beautiful.
crazy.
That's good. So, at what point, guys, do you start figuring out these no options are probably you can find them early on? Because I think that's where we should probably be going. And I put that slide in my talk where if you have a high MAC, meaning a high calcification pattern, and you have a pretty bad wound, chances are you're probably going to arterialize this patient. So at what point do you guys say, we are identifying high calcium, high MAC scores? And I think it was Roberto's idea to try to create a classification. But how were those conversations when you guys were trying to identify which these patients were best for the technique?
So I think it's a great idea of Roberto. Roberto, it's very clever in my opinion, and we start to find the MAC disease in this patient,
And to give the audience a little bit of understanding, the MAC means medial
Medium
artery
calcification.
calcification. And this is the idea of with 2 X-ray projections of the foot, you can actually see the Monkberg signs, the tracks of calcium in the vessels. And if there's X amount of tracks, then that surmounts to a high calcium score, which means overall the foot, everything, the metatarsal, the digitals, is full of calcium, medial artery calcification. And those patients essentially have a different pattern of disease. And that's what you guys started understanding and then trying to classify it to nowadays being something we all normally look at.
Yes, but to be honest, we didn't start from the foot. We start from the groin. And what happened? Happened that when we put the patient on the cath lab and start to do the first X-ray to plan the puncture, what was the common? The common signs are that there are a lot of calcification, a sort of natural roadmap of the common femoral artery, iliac artery, SFA profunda. And all the patients have the same characteristic. This kind of natural roadmap due to the calcification of the wall and the SAD disease. And Roberto started to study all the X-ray, basal X-ray on the SFA, on the POP, and on the pedal artery, and I recognize that there is the medium artery calcification is not a disease of the foot, is a disease of the entire body. Because if you do an X-ray of the abdomen of the patient, of the hand of the patient, you will find the same clinical characteristic. Medium artery calcification that are a sort of rail track on the artery. And the rising question is, was if SAD disease and MAC disease was the same aspect
In
of the
SAD disease to expand
artery,
small
small
artery
artery disease, because the definition of the small artery disease, it was a definition that has been always avoided by vascular surgery, because in 1991, if I remember well, Pomposelli said, don't speak about SAD disease, small artery disease, small vessel disease, because it's misleading for the vascular surgeon. So doesn't exist small vessel disease, but they suggest us to feel the resistance of the arterial bed down to the anastomosis by flushing heparin solution. So if you do a flushing or heparin solution in your posterior tibial artery and you feel resistance, it's a patient with high resistance, with high disease of all the vessel BTA. But we cannot speak about small vessel disease. So we start to speak again of small artery disease. And it was, perhaps, if I don't remember, during a summer school in which there was Chris Attinger, Robert Freiberg, in which we discussed for the first time of our experience of 10 patients. And it was a sort of collegial idea that perhaps there is a new actor in CLTI patient, and we are facing to a new kind of disease. But the raising question is why? Which is the problem that lead the patient to a SAD MAC disease, respect a patient that haven't no SAD disease but only a big artery disease? All the patients are diabetes, all the patients have a renal failure, but what is the difference? Why some patients develop a MAC disease and the other patient no?
Maybe the answer could be the neuropathy, the role of the neuropathy.
The role of the neuropathy, and perhaps the role, in my opinion, of the junk food. Probably, because
Maybe.
No, but I think the hemodialysis itself, those because those are probably the worst patients in the way that I've identified it.
Correct.
It seems like there is in renal failure patients. This is a paper I like quoting a lot, where the vascular, the smooth muscle cells, when exposed to high levels of calcium and phosphorus, and some of these derangements that happen in renal failure, they phenotypically change, and the VSMC now actually starts depositing nanocrystals. And I know this is hypothetical, but for me, that's the patient. When I moved from Arizona to Houston, that was when I had my uh-oh moment, right? That's when I'm like, nothing that I do works.
In San Antonio, it's worse.
And nothing that I do works. And what I could constantly see was that it was typically renal failures. So, they would have their AV fistula. They would, I would probably see them for that. Then, I have a wound in the toe. Then I would go try to get through the calcium, open something, maybe do a little atherectomy with a CSI, whatever. Occluded in 2 months, occluded in 3 months, and then chop, 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 what Roberto says, the salami effect. Pop, 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 pop. You're going back, and it's...
Roberto gave a talk, I don't know
Unstoppable.
where I saw it, but he looked at the histology of it. And it's very interesting because a lot of the lumen loss is due to neonatal hyperplasia, which is the phenotypical changes in the smooth muscle cells. So if you look at that, you're like, okay, like what we're doing doesn't work, because what we're doing is not meant to treat smooth muscle cell proliferation in 2 millimeter vessels. So for me, why, if you look at that, why CSI? You're just gonna
Correct.
embolize all those smooth muscle cells down. I don't know.
I think that the next episode of this story could be the selection of these patients. It could be to know exactly we must exclude from the beginning to for this kind of revascularization, because I think that if we collect all the data we have all around the world, I think that we could have the answer to exclude or to include some patients and not some others.
Are you guys treating end-stage renal disease patients with arterialization? Because I stopped. I wasn't having. When they came to me, at that point,
That's exactly the patient that needs it.
But they have a high failure rate. We saw that in the trials. They have a very high failure rates compared to.
But that's dragged by mortality primarily.
Yeah, exactly. Because those patients.
So then you stop treating them because they die?
Yeah, because they're gonna die, and within a very short time period. And do these patients want to be struggling with a wound for the year? Because it takes 8 months to heal on average. So
what
that's what they have to
offer them a major amputation.
Yeah, that's what I started doing.
That's pretty categorical. What do you think about that? Andrea, I'll put you on the spot.
You must be honest with the patient and told the patient that if you carry on a major amputation, the risk of the mortality is high. And but I understand also your point in the time of healing. It's very long respect the diet revascularization, and in my opinion, it's not a decision of us. It's a collegial decision with the patient. What I told to the patient, what we told to the patient before an arterialization, for example, is you must fall in love with me because you will see me for 4 or 5 months,
Yeah.
more than your wife, and sometimes it's better.
Yeah,
And-
what I've tried to do is try to identify early issues that lead to mortality, specifically cardiovascular. And if I'm going to put the patient through the ropes, then I'm going to talk to my cardiologist and I'm going to say, hey, this guy's bad protoplasm. They've got AV fistula, they're in stage renal disease, but they want to save their legs. And I want to do as much as I need to do. Would you mind also looking at the heart, maybe making sure that maybe he doesn't have an LAD lesion that needs to be treated ahead of time? But I don't know that I have categorically already said, no, I can't treat you, or that I lean towards a major amputation as a way for those patients. I almost feel that is the perfect place. But, like everything,
I think it
yeah,
also-
you're about to say
I
something,
think
Giacomo?
yeah.
No. I want just to say that it's a very hard decision. I think that today we do not know who could be eligible for a quite high probability to achieve the goal or not. So I think that today we do not know the answer to your question. I think that as Andrea I've just told, I think that we have to talk to the patients, we have to talk to the relatives, to the family, etc., and to explain what the arterialization protocol means. If you do not have compliance, if you do not have the attention of the patients, because as you have just said, is a long treatment, not just the arterialization, foot care. You have to wait 90 days when it is possible, because we have to talk about the risk of infection during these months and during this week. You cannot use, for example, the same follow-up you have for regular diabetic foot patients. These patients must be visited regularly in a very short period, etc. We have to check for infection. We have to check for many other things that usually you are not used to check.
And I think when we talk about this, we have to kind of lay a foundation that your situation with Brian Lipo, which is a brilliant podiatrist, you guys working together is very different. Because I've had a lot of friends reach out to me and say, hey, can you help me, start doing these things? And for me, I'm the podiatrist. So even though we had Dr. Ross, even though we had Brian, to be honest, when I was training, that wasn't my priority. My priority was vascular surgery.
Yeah.
So I did procedures with them, but I don't have the podiatry expertise. So I have to understand my own limitations in that. And for the foot care, I still have a significant learning curve compared to Giacomo, compared to Brian. So maybe that's why.
Yeah, but I think that's a very honest. It's a very honest thing to say, because also, you need to focus on your vascular care, and if you open the floodgates to podiatric care, then you're going to be stuck every week doing foot care.
Yeah.
That, let's be honest, in America doesn't pay well.
Yeah.
I mean, I don't know if it pays better in other places, but in America, the reimbursement tied to that is really bad, and that's why there is a necessity, even from a financial standpoint, to have a toe and flow team, because the podiatrist needs to be offloading the surgeon so that each one does their part, but they work cohesively, right? There's a fluidity in that conversation. And I'm seeing this I'm going through this pain because now I'm in a different hospital system. I did bring Brian on, but what happens is now the podiatrists in this other hospital are sending me no option CLTI patients. But they don't know how to treat the arterialization podiatric. So the first thing they do is they see the patient a week later and they're like, oh, you probably need a below the knee amputation.
Yeah.
1 week later after an arterialization. So I have to go and talk to the podiatrist again. Why are you saying this? I told you it was different. I told you had to wait.
Yeah.
Why did you open your mouth? Now you're
Yeah.
losing hours of your day talking to the sister and talking to the mother and talking to the brother.
That's a
And
huge
it's
part.
so
It's a
much.
huge, like, and not just like when they're in the hospital, every single person comes into the room like after you've done it,
Oh.
and they're like, "Oh, this looks way worse." And it's like, I've told every single person in this hospital that this would happen, and just like,
Listen, I did this. I talked to there's this one case, and with this we got to start closing out. But there's this one case that I pulled this new podiatrist in. I talked to him for an hour. I told him what I was going to do. I talked to the family for an hour, and I told them what I was going to do, and everybody was fine. I talked to the internal medicine guy taking care of the patient. And it happens that I was going to Costa Rica for a vacation with my family. So I'm like, okay, everything's good. He's in autopilot for the next 2 weeks.
Yeah.
So I leave. Second day, 48 hours later, the internal medicine guy says, the guy has a fever. The leg has to come off.
yeah,
Have you explored other reasons for this? It's
Yeah.
open. There's no infection. So the podiatrist comes and says, well, I'm not sure. Let's get a foot MRI.
oh my god,
And this quest for ridiculousness starts. And they listen what happened because I'm out and I say, I am out of the country. I told you guys what to do. I don't want to receive more calls about this.
yeah,
Nobody touches my patient. They go and they call another vascular surgery team. Thankfully, the vascular surgery team respects me.
Yeah.
They call me. They're like, hey, we were asked to give a second opinion. What do you want to do? I said, don't do anything. They're like, okay, we'll leave it alone. So you know what they do? They call orthopedic surgeon to see if they want to cut the leg. Okay, so the ortho guy comes and calls me. He's like, hey, they want me to cut the leg. But your note says, do not cut the leg for 2 weeks.
Yeah.
I said, please, don't cut the leg. And the story goes, this guy is now grafted and walking and doing fine.
Yeah.
It just was a matter of time. And so these things are important, all these other sides that you have to control.
The experience make the difference.
Totally.
The experience. And it's amazing because probably now after perhaps 100 of hybrid arterialization, we
100.
Yes, we just know how is the fate of the patient. We just know. We look in the eyes.
Do you still think now that you've got
30%.
100, now that you've got 100 plus, do you still think if we start with the idea that these are no option patients that are probably going to get an amputation, do you believe that 70%
Yeah.
is
70
appropriate?
65, 70%.
Yeah, less than
65.
70, but I will talk about 60, 65.
65,
Yes.
yeah.
What do you think the 35 that don't do well? Do you have an explanation, Giacomo?
Wrong indication, wrong patient.
Some patients, yes. For example, inflammatory patients, in my opinion, must be excluded by the.
Acute limb ischemia needs
No.
to be excluded.
The last case that I show in my lecture, it was a patient in which there was no indication to arterialization, and Giacomo told, in my opinion, is not a good candidate, but we are in front of a patient in.
It's difficult to.
It's very difficult because he was a young patient that slept 3 months in the chair, and he didn't want to lose his leg. So it was very difficult because we saw sometimes we saw the amputation as a failure of our work, but we must remember that sometimes a limb salvage is only in our mind. We must talk of functional limb salvage because the limb salvage by themselves is only in our mind because the patient is a patient that undergo 5, 6 procedure, go in the OR, go in the cath lab, go to the podiatrist, go every day
Maybe with
dressing.
an healing ulcer for years and
So,
years, and maybe
what
major
kind
amputation is
what
done.
kind of life we guarantee to our patient?
Yeah.
Patient 8 month, 9 month of continuing dressing, infection, medication, don't peer on the foot. So sometimes it's only in our mind, and we look to the amputation, major amputation, as a failure. But back to the first patient, the last patient, it was a wrong indication because it was a sort of subacute ischemia. We tried to do something, but we failed. But I don't know because nowadays, after 5 months, we have still the leg attached, and we saw a little bit improvement of the lesion on the foot. That's why I told you it's a wave. We have the first step in the post-op that we are all of us are happy because the system is working, the pain is going away, and the lesion appear well. Then we have the shock phase in which there are all is going worse. You have a progressive failure of the blood flow on the foot. You have a worsening of the ischemia, worsening of the ischemic lesion, and we learn to be patient, and to take time. I think that as a surgeon, I could think, because in my opinion, is the surgeon has a different mentality of the internal medicine. He wants to do all
We are more
faster.
intelligent.
Yes.
You want to resolve.
You want
resolution.
resolution. You have
Yeah.
a patient with pain. You go in the cath lab on the operatory theater. You treat the patient after 3 hours, 4 hours. The patient is going out from the cath lab you are without any pain.
Done.
You solve the problem in a couple of hours.
Yeah.
That's our force. That's our ego.
Yeah.
And in this case, you force yourself. You force your mentality because you have not to touch the patient. It's if you are in DOR, the worst thing that you can do is touch something that is going well. If you don't know if it happened to you, but when I complete my for example, more anastomosis or my TIA, I'm looking to the TIA, and I start to touch here. I start to touch. There is some bleeding. I give another stitches on the point. And in the happen this disaster, because you didn't touch anything, and that's the problem with this patient. You must be waiting and taking your time. This is the most difficult
Patience.
thing that a surgeon can do. Take time.
Listen, guys, we could talk hours.
Hours.
I want to be respectful of your time, the fact that you may have probably some other conference engagements and needs. This has been enlightening, to say the least, inspiring, and hopefully some young people out there after this history can understand that it takes mavericks, it takes people to push, it takes people to, I mean, it's amazing. So, guys, thank you.
No, thank you.
Thank you.
For this very
This has
nice
been
talk.
beautiful. It's going to be on all the podcasts, Spotify, Apple. We can certainly share it with you guys. And hopefully the speakers out there, the listeners out there have enjoyed it today. Lucas, any final word?
No, thank you. I mean, this was amazing, and I think this was an important conversation.
Yeah, very important one, very timely, and a whole lot more to come on arterializations. We are just starting.
Yeah.
So hopefully there will be other people out there to push this even more forward and understand the technique and understand exactly who gets what and when. So to all of you out there, thank you very much. Pura vida.
Grazie.
Ciao.
Thank
ciao,
you,
ciao.
ciao.